Afternoon, good morning. Hello to all who have joined. I think we'll give this just a few minutes to begin our conversation today. We've got an exciting panel who will be presenting, so looking very much forward to a robust conversation and learning new things, certainly, about this very important topic. So let me give a few minutes just for additional participants to join us. It's 3:02, and I want to welcome everyone to the call today, to the panel discussion today. I'm wondering if we should give just a minute longer for additional colleagues and friends to join us. So if we can just add one more minute to before we start, that would be great. Thank you so much. Once again, hello, and a very warm welcome to our distinguished guests, friends, colleagues, champions of health and gender specialists who are joining us from all over the world. My name is Des Talaga, and I'm the Group Director of Partnerships and External Affairs at Amref Health Africa. It's such a pleasure to be here today to moderate the session and discussions that we're having. It's really my pleasure to welcome you here today to this high-level event that's co-sponsored by the Frontline Health Worker Coalition and Women in Global Health on a topic that's very near and dear to many of our hearts. Throughout this 90-minute webinar, we want to hear from you. So please do introduce yourselves in the chat function on the bottom right-hand corner. And send your questions for our speakers or share your thoughts on Twitter using the hashtags that we are now putting in the chat messages, and make sure that you are sending your chat messages to everyone and not just to the panelists, because I'm sure there's quite a bit to be learned from one another in this session. This event is being held on the sidelines of the 10th Annual Health Worker Week that's celebrating frontline health workers and elevating their voices, their roles, and needs. And this year's theme is Build the Workforce Back Better. So as we enter into the third year of the global COVID pandemic, yes, it's been quite a long period. It's really important for us, I think, than ever before to bring to the forefront the important issues that are surrounding women healthcare workers' remuneration. Women, as we know, have had to bear the brunt of increased unpaid work, not only in their roles as healthcare workers on the front lines of health systems, but also outside work, caring for children and relatives and family in general. So today we'll be hearing from some inspiring women from government, non-governmental organizations and communities themselves. And I'm very happy to be able to really welcome and introduce our first guest, Dr. Magda Rabalo, who will give us an introduction to women in global health and the organization's work to highlight and understand women's unpaid work in health. And Magda is the managing director of Women in Global Health and has decades of experience working in the fields of public and global health. She was the Minister of Public Health in her home country, Guinea-Bissau, and one of the only women in the world to lead a national COVID task force, 19 task force. She's also worked with the World Health Organization for many years. So it is really my pleasure, Magda, to welcome you and give the floor to you. Magda? Unmute yourself, please. Yes.
Thank you. Thank you very much, Tessa. On behalf of Women in Global Health and on behalf of our Executive Director and co-founder, Dr. Rupa Das, it gives me great pleasure to welcome all our eminent speakers, our moderator, and audience for this event today, which marks World Health Worker Week 2022. And I must wish you all a very happy World Health Worker Day. We have entered the third year of the pandemic And today is definitely the right time to remember the health workers lost to the pandemic and to thank all health workers for their extraordinary service. I also would like to thank our partner in this event, the Frontline Health Workers Coalition, for their collaboration and their important work in the field. Our event today asks whether women who work unpaid in health systems are actually subsidizing global health. The COVID-19 pandemic struck a world with highly unequal access to health services between and within societies, and the serious health worker shortage. The United Nations Commission on Health, Employment and Economic Growth projected that 40 million new health sector jobs will be needed by 2030 globally, and 18 million will be needed to realize universal health coverage in low and middle income countries alone. Women, as the majority of workers in this sector, should in principle be highly valued by the societies they serve. It has, however, been extensively documented that women health and care workers face discrimination at work on many levels. Women are clustered into lower status roles in health and care and marginalized in leadership, and they earn on average 28% less than their male colleagues. In addition, today we will hear from women in global health and our speakers about the women who deliver essential health services in their communities and receive no pay. COVID-19 has shone a light on the disproportionate burden of unpaid work done by women in their homes, in their families, in their communities, a burden that has increased everywhere in the 2 years of the pandemic. The pandemic has shown us how far societies and economies rely on women's unpaid work. Women community health workers have been the backbone of the public health response in many countries, tracing COVID cases in their communities, supporting infection prevention and control, and delivering vaccines. As we'll hear from our speakers, the unpaid work women do in health systems a significant value for the health, well-being, and social cohesion of their communities. Women in these unpaid and underpaid roles are often the first and only point of contact with the health system for women in their communities. We want to change the narrative. We should change the narrative and see these women not as volunteers, but as community-level agents of change. They are the experts in their own context. We want them to be paid for the valuable work they do, and we want them to lead. We will hear today from my colleague, Anne Killing, from Women in Global Health, who will share the work we have done on women's unpaid work in health systems, and we will then hear from our other inspiring speakers. I trust you all enjoy the session today, and thank you once again for joining us in this important event where we'll be launching a policy report on women's unpaid work. Thank you, Dasta. Thank you for the opportunity.
Thank you very much, Magda, and you raised such important points in your welcome, and certainly women receiving 28% less than male colleagues is just an untenable number, and indeed they are community agents of change. So thank you so much for setting the stage for us. And now I actually have the distinct pleasure of inviting Anne Keeling, a senior fellow and Women in Global Health Women in Global Health author of Subsidizing Global Health, Women's Unpaid Work in Health Systems Report. Anne wears so many hats, and it's such a pleasure to have you here, Anne. In her 40-year career in global health and social development, it's included posts in Pakistan, Papua New Guinea, Indonesia, the Caribbean, Belgium, and the US, her home country, in the UK as well. And she's held the post of Health of Gender Equality Policy with the UK government and is currently the chair of the NGO Age International and Senior Fellow of Women in Global Health. Anne has been the CEO of 2 global health NGOs, and she's founded the Global NCD Alliance and was the UNFPA country representative to Pakistan. And it's such a pleasure to welcome you. The floor is yours to tell us more about this new policy report that Magda referred to. Over to you, Anne.
Thanks, Esther, and welcome to everybody who's joined us today. Thanks, Becca. I think you're moving the slides. Or Sky? Great, thank you. Next one, please. So this policy report that we will launch in full in a couple of weeks' time dates back to the first report on this broader issue of gender equity in the health workforce that was produced as a WHO report in March 2019, authored by Women in Global Health as part of the WHO's Gender Equity Hub. And that report was Global Health Delivered by Women, Led by Men. When we wrote that report, we flagged the issue of women's unpaid work in health systems, but there wasn't much information. Thanks, Sky. And this is the basic problem that was flagged in that report. Women are 70% of the majority of the health workforce, but they hold only 25% of senior roles. We've seen women losing ground in health governance during the pandemic. Women are still clustered into lower status, lower paid roles in health. There's a distinct intersectional angle in that in many cases, the lowest status jobs are held by women from racial and ethnic minorities, etc., migrant women. Bottom and in the middle there is that, as Magda said, women are paid less. The gender pay gap in the health sector is 28%, but on top of that, there are a large number of women working unpaid and underpaid who are not included in those statistics. And violence and harassment is so common in the health workforce against women that it's almost treated as normal, and it's increased in the pandemic. Thanks, Sky. Going backwards. Still going backwards. Okay. So we set out to write this report looking at this figure that was produced by the Lancet Commission in 2015, that women contribute $3 trillion to global health every year, but that half of that is in the form of unpaid work. And in the pandemic, women's unpaid work has really been highlighted by the women on the front lines in the pandemic. So we were asking how many women are working unpaid? What sort of work do they do in health systems? Why do they do it? What's the impact? And what can we do? Thanks, Sky. And I want to give you just some headline findings. It's very hard to calculate the numbers of these women when so many of them are treated as volunteers and they're not counted in official labour market statistics. But we have identified a minimum of 6 million women, community health workers, who are either unpaid or paid via low performance-based stipends or incentives such as bicycles, mobile phones, etc. We have found other examples of women elsewhere in the health system, for example, nurses in Mexico, but it is unusual outside humanitarian settings. There are some men working in these unpaid roles, but the majority are women. Generally, these women come from low status, low income, and low educational level backgrounds. And as I said, there's a very strong intersectional angle here. In some contexts, these low paid women are disproportionately from marginalized caste, religions, ethnicities, etc. Thanks, Sky. And what type of work are they doing? When we look, the sort of women that we're looking at are doing, they're doing work that is core health systems work. They're delivering basic treatments, diagnostics, referrals to the main health system, vaccinations, health promotion, and they're generally the critical interface between their community and the health system. And in the pandemic, we've seen these women on the front lines doing contact tracing, health promotion, vaccinations, and they had a sudden increase in work and were often unprotected by adequate PPE, for example, because they were at the lower end of the health system's hierarchy. Women working unpaid are often remote in communities, which makes them harder to organize because they're not in one place. Thanks, Sky. So why do women take on these roles? These are some of the busiest women on the planet. They already have a very heavy burden of unpaid work, farming, etc. Women have a very strong ethic of serving their community, especially we've found other women and children. But their choices of career, their choices of work, their choices of livelihood are constrained by gender, power, and poverty. As women, they may have limited mobility. They can't necessarily go and seek work in a different place. They're less likely to have finished secondary school, so they don't have the qualifications to get formal sector work. And there are also issues of status and respectability about the sort of work that women can do in their context. For some women, many women, it's an opportunity that this unpaid work may lead to paid work, and there are other incentives that may come with it, such as a mobile phone. Status and autonomy are very important. So for some women working in highly conservative social setups, actually getting out of the house to do something meaningful is important, and it gives them autonomy. But at the bottom line of all of this is that unpaid work undermines women's economic rights and their potential, and it reinforces lifetime poverty. Thanks, Sky. What are the impacts for health systems and for women themselves? In the short run, it may mean that health systems spend less, but those health systems in the end are built on the fragile foundation of unpaid work and essentially rights abuses. And this impacts health system performance and accountability. There's often quite high levels of attrition amongst unpaid health workers. This increases the burden of work on the poorest women. And with the pandemic, this was very much so. And we saw some, and a good example are the Asha Cadre of community health workers, that's around 1 million women in India, organized and went on strike during the pandemic with some positive results. But essentially, this unpaid work is driven by and reinforces gender norms and inequality. Women are said to be altruistic volunteers. This is said to be voluntary work that empowers women. And the truth is actually quite different. Thanks, Sky. So just 3 closing messages. We have seen countries bring this unpaid work into the formal labour market. Feasible policy solutions exist. There are precedents this can be done. Secondly, bringing women's unpaid work into the formal labour market is urgent, and it's urgent both for women and it's urgent for health systems. And thirdly, when we're talking about bringing back equal after the pandemic, bringing back equal must mean addressing women's unpaid work in health system. Thanks, Guy. And finally, we would say that when we get this right, and when we get safe, decent, and equal work for women in the health workforce, it will have a triple gender dividend. There will be a health dividend. At the moment, we have an 18 million global health worker shortage. If women have safe, decent, and equal work, they will be attracted into the health workforce to fill those jobs, and they will be retained. Secondly, bringing women into the formal labour market will enable women to engage, to be part of leadership, and will increase gender equality as women gain more income, more autonomy, and decision-making power. And thirdly, there's a development dividend that by creating new jobs in health, these new jobs in health will fuel economic growth and strengthen health systems and outcomes which will all contribute to universal health coverage and our other health goals by the 2030 end date. So this is a win-win-win solution. Thank you, and I'll stop there.
Thank you so much, Anne. And you know, you brought up so many interesting and important factors, and I think that we should actually pause and just think about what you've said, because it's so critical and so important. I mean, how do we strengthen health systems? And I think, as you said, part of that is really building a strong, empowered, remunerated health workforce that is, gender sensitive, and ensuring that women are also brought into the fold, because that will result in that triple gender dividend that you talked about, improving health and strengthening the health system, ensuring leadership roles for women, and certainly economic growth in general for the country. And thank you so much. I think that is really at the heart of improving and strengthening our health system, is really addressing that gender equity issue. So you've really brought it out very nicely, and I really appreciate that. And we are looking forward very much to reading the entire report once it's released, and I believe that's next week. So very much appreciated, and we'll pick up this conversation again a little bit in the panel. So I now have the distinct pleasure of inviting Linda Edem to the floor. Linda, it's been such a long time since I saw you. Always great to see you and see what's happening with you. Linda is the Special Assistant to the President on the White House National Security Council for Development, Global Health, and Humanitarian Response. As an advocate leader with 2 decades of experience in national security, global development, and conflict mitigation, she is passionately integrates her experience in foreign policy and humanitarian response in the fight for equal dignity and rights of all persons. She is committed to inclusive development for social impact and empowering communities and creating a world where individual potential and freedoms are realized. And most recently, Linda led the Biden-Harris Agency Review Team on Global Development and Development Finance, and she chaired the policy initiatives on the global COVID-19 response. So Linda, thank you so much for joining us today, and the floor is yours.
Thank you, and that's quite a welcome. Maybe I want to start by just thanking all of you, DESTA and Women in Global Health, and of course, frontline health workers, for convening, I think, this really important discussion. We have been talking about this challenge of women's unpaid work for quite some time, and it's great to see some of the momentum behind these efforts, some of the research that's underpinning these efforts right now. But we know that studying the problem is not enough, that action is what actually changes lives. And what I'm really excited about even more is that there are a lot of people who are on the screen today who are going to roll up their sleeves and talk about what the next stages are going to be. I was asked to come and speak a little bit about what the Biden-Harris administration was thinking and doing in this respect. And I think it is important to sort of place our administration in the global context that we're all in right now. Obviously, the COVID-19 pandemic really shed light on a lot of the inequalities that we were seeing already in society. It was really important for us to be able to actually see in really stark relief how many women, not just in countries that we were considering ourselves sort of donors to as the United States, but in our own country, seeing women leave the labor force as they sort of grappled with the need to be caregivers and the need to actually pay attention to their day-to-day work. And what that sort of spoke to more than anything was the expectation underlying multiple societies, not just in one area of the world, but across the entire globe, of where women should be placing their expectations in the workforce and how they should be compensated for that work. What it really revealed, I think, more importantly, was the overall fragility, I think, of the world's global health systems due to this over-reliance on underpaid or unpaid, poorly treated and harassed, overstressed female health workers. And I would say the broader sort of health worker sort of definition, we also include sort of the care workforce as well. I think, Anne really laid out a lot of the stats, and so I'm not going to sort of throw them out again. And I think, when we were looking at the challenge, we see it as multidimensional, because if you sort of only address it as a gendered issue, and you're not paying attention to how it fits into your broader sort of global COVID recovery efforts as far as the health systems, or if you're not paying attention to the economic recovery efforts, you're missing very important pieces of it. And so what we've done as an administration is said that this information needs to be mainstreamed across multiple lines of effort. And we need to be paying attention to how we're addressing or not addressing this issue in multiple ways. The first is, I think, the most obvious, right? There are community health workers, women across the world that are actually directly delivering service and doing this work for free. They are considered volunteers. Maybe they get a cell phone, but they are out there doing this work, and they're not being moved into the formal health economy, despite the need for more jobs in many of these countries, despite the need for a more stable health system and more regularized work, despite the need for additional training for the global health workforce. You have a sort of community of people who are there, who are already delivering, who are working really hard, who have that sense of service and community, who have been vetted in many ways because they're working with so many of our projects and programs and organizations, and yet the pathway that they have to sort of being formalized is stymied. We sort of have looked at that as, is that, again, with a lot of the research that you were just identifying, is that a financial issue? Is that countries who can't afford this? Or is that also a question of not actually calculating the worth and the need and the necessity of this work to begin with? So we begin by trying to characterize the work more intentionally. And so you'll see throughout all of our documentation and many of our programs, especially PEPFAR, I think the President's Malaria Initiative, I think Dr. Raj Punjabi is going to be speaking later as well. And some of you might already know him from frontline health work. But, he in those sort of initiative-specific areas, the administration has already taken steps to be able to say, in our programming, we used to have rules that would disallow us from funding community workers as part of contracts because it was seen as unsustainable, right? And so we wanted to have pathways for sustainability. Well, those stipulations have been revised, both in deep consultation with a lot of the community leaders and a lot of the workforce there. And so, you'll see some of those adjustments just in the basic policy. So, again, it doesn't sort of solve country budget issues. It doesn't solve sort of these grandiose things, but I think it allows us as the US government to sort of walk the walk and talk the talk at the same time. The second issue I think that we see a lot is this idea of this pipeline problem. And so we have trapped women in, I think, a lot of these sort of opportunities. And so in a lot of ways, when we talk about addressing these global gender issues, I think there's a very strong feeling that we should just start by not thinking about this as a systems-wide challenge, but only addressing one sort of piece of it by potentially looking at only the stipends or, for a community health worker versus thinking about how do we work with governments and partners to look at pathways into a formal work sector if they so choose, but also looking at the other side of the pipeline, which is women who are already in the formal market, who are being underpaid, who are being harassed. Again, there's a disproportionate amount of violence against women in health, as well as a disproportionate number of, sort of women just being harassed in sort of hostile work environments. We see this across the world. And so, fixing that pipeline issue allows for you to more easily develop that pathway in. Because again, if you don't change the culture of the workforce in the first place, you don't sort of set that level of expectations, then it doesn't feel as obvious for how you onboard and retain, I think, women who need to be in these spaces in stronger and more powerful ways. And it doesn't set up the expectation that this is where they can go. And so, in looking at some of that work as well, we have been spending a lot of time sort of working with WHO and other international organizations around sexual exploitation, assault, abuse, and harassment. How do we make sure that instead of just having words around, no zero tolerance, we actually move those words into action? So what does that mean? It's not just about an allegation of one particular incident. It needs to be about a culture shift and a culture change that allows for organizations and health systems to have the expectation that this is something that is an actual health issue, which brings me to the third point, which is treating this as the health emergency that it is. Global health systems are fragile because they rely on unpaid work. They rely on a system where we're not effectively training the backbone of the delivery system. It doesn't make a lot of sense, and we know this. We also know that women in these spaces are overburdened and overworked and suffer disproportionately from mental health strains, stress, and outcomes. And so again, putting this together, it just is a recipe for a collapse. On top of which, you identified that sort of magical number. We are facing an 18 million worker shortage globally. This affects everybody, not just developing countries or lower income countries, but every country in the world is grappling with the fact that we have a health worker shortage, and we need to make sure that we are keeping the people that we have, we are giving them pathways in to retain, and that we are encouraging half of our population to be part of the solution here. And so, again, looking at it across these boards, I should have mentioned the other piece, which is the education. So there's an educational component of this as well. So when women and girls are sort of offboarded too early out of the system, that seems to be the only answer. It becomes only about retaining women and girls in schools. And so having really important conversations with our Global Partnership for Education colleagues and some of the complex settings around how do we get women and girls back into educational settings even after they've been off-ramped. So there's the assumption that once you've left school, you can't come back. If that's the case, we're in a deep amount of trouble because of how many students we've lost through the pandemic who had to leave school, who may have started families, may have gotten married, but that can't be the final solution. And so looking at flexible ways of looking at training, that has to be part of the solution for women in global health. It has to be the solution for this workforce. So again, pathways in for folks who are being unpaid right now, looking at our own programs internally, so making sure that we are walking the walk with our own programs, encouraging other donors to do the same, and then breaking down some of the barriers to doing so with the governments and countries themselves. Next, making sure that we are paying attention to that whole pipeline of issues from education to retention, so that there is a culture that's there built on sort of the expectations led by WHO and some of the reforms that they are looking at when grappling with sexual exploitation and abuse issues there, so that is seen as a public health issue that we all need to address. And third, making sure that we look at this as sort of the economic issue. So underreported work that women do, making sure that we're linking it to other parts of the economy and what that looks like to build back better for the global economy. So those are sort of the ways that we're looking at it. We know that, again, it's very bureaucratic at this point in time, but we think bureaucracy changes lives. and so this is our first push. The next piece, I think, is that we know that we need to work together as a global community on this. The United States can't do this alone, that we're going to be dependent on the countries themselves sort of taking up action, that we need to walk our walk. So we have a domestic health worker initiative that we launched late last year. And that was just focused on the United States. It was focused on sort of what we looked at for paid and unpaid work. we think that's a way of modeling a lot of the belief system and the structure for what we want to see in the world. And so we wanted to make sure we were walking the walk first before we go out there and sort of lend our advice to others. And we know that there are a number of other partner governments and countries that are coming in as well. And this is the next phase. Really, honestly, this is the next phase with bringing us all together and making sure that we pay attention to that big number, because the health worker shortage, this unpaid work, the fragility of our global health systems are a global problem and not one for any one country. So that's it. And again, thank you again for inviting me today.
Thank you so much, Linda. And I think you touched on some really important points. And I think absolutely our global health systems are fragile, partially because they rely on unpaid health workers. So really important point that you're raising there. And I mean, I like the way you're thinking about examining the entire pathway, including education and training as part of the solution. Certainly creating safe spaces for women is important and critical. So, how do we really, I mean, it's really excellent to hear that there are some adjustments being made in policy by the USG, and certainly that you are looking to work with other governments to ensure that you break down some of these barriers. Those are all interesting and good to hear. There are some questions that are in the Q&A, if you can answer them, because I think some of it has to do with what are the opportunities that exist for women's unpaid work in health systems, particularly LMICs. That's really important because we find a lot of unpaid health workers in the LMIC space. And then there is another question, Linda, that you might want to address, which looks at really, shifting away from the way we're doing funding currently. And instead of doing it the way we do it now, directly funding women-led community-based health networks. So that kind of talks to the localization agenda, which I know is really important for the US government as well. So maybe you can just take a look at some of those questions as we move on to the final intervention before we move on to the panel discussion. So thank you so much, Linda. Really well put and well framed discussion that you've brought up. So as the final intervention, really before we move into the panel discussions, I'd like to give the floor to Ms. Uniter Adoyo, who's a community health worker from Kenya. And I always think that it's so important for us to really hear the community voice. That's really important for us to amplify. And I'm glad to welcome Uniter to this discussion. Uniter is a mother of 3, and she's married in Luala village in North Kamangambo, Migori County. I'm based in Kenya too, Uniter, so it's great to see you. She possesses really true passion for community work, and when she started engaging with Luala Community Alliance's health interventions, she was able to acquire some knowledge and skills that enabled her to manage health issues at the community level. So Uniter is actually where the road meets the rubber. This is where it's really important. She's the one with complete access to community. She's had extensive training on integrated programs in various community interventions and programs that are vital to the well-being, development, and sustainability of the community as a whole. She is a team leader in charge of 96 community health workers in North Kamagambo, where she's responsible for planning and coordination of all community health and clinical activities. She plays a critical role in recruiting community health workers, mentoring youth peer providers in Luala, and she's also a trainer of trainers. So Uniter, it is such a pleasure to welcome you, and the floor is yours.
Thank you very much. I'm Unita Adoyo, a community health worker for Migori County Ministry of Health, supported by Luala Community Alliance. As been said, we've gone through several trainings of maternal and child health, ECD, that is early childhood development, WASH, that is water, sanitation and hygiene, including HIV and AIDS trainings, nutrition, we've gone through sexual reproductive health, and GBV, that is gender-based violence. So in this, all the programs that cuts across, we have several duties that we do as community health workers. That is, we do identify cases in the community, do referrals, follow up, and do some treatments for these ailments like malaria, pneumonia, and others. Concerning the sexual reproductive health, we do mobilize them, we refer them to take these services at the health facilities, and there are some that we do give or we distribute to them, like the pills and the condoms. And on the maternal and child health again, I've said we do treatments. We are concerned about the PSBI that is possible, serious bacterial infections that affect our newborns. So whenever we identify such cases, we do refer to the health facility for management. And again, concerning the malaria and pneumonia, we do screening and tests. And when we find the positive cases, we do give the drugs as prescribed. Again, on the HIV and AIDS patients, we do give follow-ups and health education and psychosocial support to these people, because we know that with them, they have a lot of challenges concerning health services. So we do give psychosocial support. We encourage them to go and take their medications as scheduled. And again, on nutrition, we do the screening, and whenever we find a malnutrition case, we refer these cases for management to the health facilities that are nearer to the client. Concerning the ECD, that is early childhood development, we do organize parental sessions whereby these caregivers are given health education concerning how they can manage and play with their children, and give the necessary, like the parental guidance. We help them do the registration for medical covers, which of course, when they do that, we are very sure that everybody in the family will be catered for. We do also encourage them to enroll the birth certificates for their children in such a way that whenever the child gets sick, the medical cover can as well cover the children. Anyway, concerning our health, our workers, community health workers, we do a lot. I said we even mobilize the community members concerning the health issues that are there in the community. We identify cases that I've talked of. That includes whenever there's a pandemic, especially the one that just passed through is still current, that is the COVID-19. We as community health workers, we do a lot. We were involved in contact tracing, whereby for the positive cases, and also give home-based care for these clients. As for that, we know women are known to be caregivers and providers, but we are not being paid fairly. And some of us are not even being paid at all. So as women, we know we also have our families, whereby we do take good responsibilities for those family members. But sometimes it becomes a challenge because I may take most of my time in the community, doing my community work and not attending to my family members. And this one has also given us a challenge because of the unfair pay that we have. You cannot at least do all the responsibilities in your family. For example, our children may not even attend school as required because of the unfair pay we have. You spend most of your time in the community, leaving alone the family chores. And as the cultural norms, women have to do both at a time. So to our end, we find that women are even paid less by 23% compared to our male counterparts. This cuts across all the programs whereby you may find women are given the lowest amount as compared to these other people. So as a woman and a community health worker, I would wish that all the women are paid fairly and they are being considered for whatever work that they do, both in the community concerning the health issues and the family chores. Thank you very much.
Thank you so much, Uniter. Your voice
Back
is
to you.
important. Yes, absolutely. Your voice is really so important, and you really highlight the issue of unfair pay and big responsibilities that are on you. And I think the work that you do in the community is not unseen. We see it, and we are collectively moving to try to shift things so that we can support our community health workers. So thank you so much, Unidir, for sharing your story. And I think now we'll move to the panel discussions. I'm going to ask the speakers to please answer the questions that are listed in the Q&A as we continue this discussion. So I have the pleasure really of introducing our esteemed panelists to the floor. Dr. Svea Klosser is a medical anthropologist and associate professor of health at Johns Hopkins. She is Johns Hopkins Bloomberg School of Public Health. Her work focuses on volunteer or low-paid female community health workers. She's also worked with ASHAs in Rajasthan, India, Women's Development Army leaders in Amara, Ethiopia, and the polio eradication volunteers in Pakistan. She's currently writing a history of Nepal's female community health volunteer program. Welcome, Svea. And then I wish to welcome also Ms. Sandra Masaya, who is the Public Service International's representative for the Caribbean, working with PSI's 22 affiliates in 20 countries and territories in the English, French, and Dutch-speaking Caribbean. Sandra is Barbadian by birth. She started her trade union career when she worked in the public service in Barbados, first as a shop steward and activist of the National Union of Public Workers, serving as a chair of the union's youth league, as an economist, and training in marketing, journalism, and communications. She brings a wide range of skills and knowledge to her work with trade unionists and her interactions with members of the civil society, other stakeholders, as well as multilateral agencies throughout the world. Welcome, Sandra. And finally, allow me to introduce Ms. Bhanupriya Rao. She is the founder of Behanbox, a platform for gender journalism. She has been an independent researcher and journalist writing on gender governance and social justice. She's a passionate advocate for open data and right to information and has worked globally across Asia, Africa, Europe on furthering transparency, accountability, and democratic governance. Welcome, Bhanupriya. So we have all of our panelists here, hopefully with us. Welcome, ladies. So I'd like to really start this panel discussion with you, Svea. You have researched health workers in many contexts who are often called volunteers and work unpaid, just as we heard earlier. What would you say to those who say that such work empowers women?
Well, yeah, first of all, excuse me. Thank you so much for this wonderful panel, organizing it. It gives me so much hope to listen to these other speakers. It's pretty amazing. But to your question, I think my short answer is that work as a community health worker, it's difficult for it to be empowering if workers are not paid a fair wage and if they're treated as low-level workers to be disciplined rather than as other panelists have mentioned, experts in their own contexts. My slightly longer answer is that when we think about empowerment, you can sort of think about it in different social fields, right? Like there's the family, there's the community, there's the health system. So at the family level, as Unidir so clearly, talked to us about, community health work increases workload. It's work. And many community health workers across the world are women who already have very heavy workloads. So the question becomes, how do you manage it, right? It can add more burden to the woman herself. It can add more burden to other family members, particularly female family members often pick up the additional work. Within the family, if workers are paid a living wage, it can actually be very empowering, because that money that they're bringing in can give them more status. Often women can keep some of it for themselves to spend however they want in ways that they may have not been able to do that before. But obviously the ability to do that depends on being paid. So that potential for empowerment is really dependent on money. And as other people have mentioned, it can, for some women in certain family contexts that are really difficult, give them a respite, some time away. And that can be really valuable, some breathing room. So at the family level, it's complicated, and living wage is sort of the main powerful way that empowerment can happen at the family level. At the community level, work as a community health worker certainly can increase respect, especially if women have curative services that people want. If all they can do is tell people what to do and give them advice, it's not often as powerful as if they have actually some services that people really desire. So listening to community health workers about the services that their community needs, and if we talk about empowerment, empowering them to provide those services, right, is a really important piece. Work as a community health worker can also carry social risks. In many contexts, it puts women into physical spaces they would not otherwise be in. This carries social risks. They can be disrespected, and it actually carries physical risks. So violence in the community is a real issue. And so the empowerment story at the community level is complex, and the best way we can sort of support empowerment rather than disempowerment is to listen to community health workers about what they need at the community level to be providing, what kind of support they need in cases of community violence, so that they can be supported and delivering the kinds of services that are going to give them the most respect. And then there's the health system, right? Because community health workers are part of the health system. Here, they're usually the lowest rung. They're usually below the lowest level health worker. They're usually not given a voice. There's sexual harassment is really common in many of these contexts. And it's within the health system that this work can really be actively disempowering. I mean, a lot of times in the health system, there's discussion of community health workers being quote unquote empowered to do what we tell them to do, right? They're empowered to deliver XYZ services, which we decided were the ones they should be delivering in the way we decided they should deliver them. And so that's not really empowerment. If it's, you should do this, that's trying to put women into a specific set of practices that someone else in power has decided is what they should be doing, rather than listening to them about what are the community needs, what are the best ways they should be addressed, and how do they want to be a part of those solutions. So that's my slightly longer answer. I do think there's so much potential for true empowerment within community health worker programs. Community health workers across the world are ready. They want to move up. They want to be heard. They want to be paid. And it's up to us in positions of power to ally with them, listen to them, and to work along with them for change. So I'm so encouraged by this panel, and thanks so much to my fellow panelists.
Thank you so much, Svea. And absolutely, I think empowerment is complicated and it requires really a multi-pronged approach. And listening to community health workers is certainly really important. So appreciate your perspective on the women's unpaid work in health and care sector. Moving on to you, Sandra. Women who work unpaid in health systems quite often work in communities in quite isolated roles. How can trade unions reach and organize unpaid women health workers?
Thanks very much, and wonderful to be a part of this really rather interesting and very experienced group. But I'm going to take the lead that was set by Svea and say that the short answer is that we work with people and we engage with communities. It is being a part of a community, a part of a society, that we're best able to find out what's going on. We actually know the people. Some of them may be our family members. And as the largest mass membership organization in almost any country, we know what's going on in the various communities. We have that inside knowledge, and our ears are always to the ground. So that's the short answer as to how we get these things happening. Our activists bring us the information, and then we develop our strategies and plans. But to get, if I may, into a bit more detail and to draw on some of the examples on what we've done in a number of countries throughout the world, in not only low and middle income countries, but in some cases in some what we tend to call highly developed countries as well. Our first task is that we make these workers visible. In PSI, we make sure that their voices, and I mean the actual voices, because then we use the technology to assist others in hearing about what's happening, to actually get a glimpse into the lives of these workers, of or the people who take care of us. We also work together. It's important to understand and recognize and reclaim this whole thing about collective action. We have to collaborate at the various levels. And because people play various roles in public health systems and in communities, it means that we also need to recognize and build on those linkages. People are involved in youth groups, women's organizations, human rights organizations, and of course the general public. And therefore through our advocacy and lobbying, that's where we are able to push for the type of legislation that ensures and guarantees human rights and workers' rights. Of course, trade unions also organize and mobilize across sectors. And it is in this ability to build and strengthen our solidarity, both within the national trade union movements and across the global trade union movement, that we've been able to work with a number of community health workers, community health aides to get things done. In terms of, in terms of at the national level, collective bargaining is what improves pay and conditions. It is what sets public policy on such issues as pay and their working conditions, eliminating violence and harassment in the world of work. And we know that that is prevalent in our healthcare settings. What we do as trade unions as well is that we campaign for the ratification and implementation of labor standards, those ILO conventions and recommendations that are particularly important, especially now in a COVID-19 era. And we don't just stop at campaigning for the implementation, we also supervise that implementation, and we work together with our allies and campaign for trade union recognition and trade union rights. Remembering, and I do want to emphasize this, trade union rights are human rights, much in the same way that health is a human right. And then if we look at the global level, a macro level, we at PSI as a global union federation, we provide guidance and support to all of our affiliates across the world to help strengthen their unions, to help them build their leadership capacities so that they're better able to manage within their local and national spaces. They also bring the voices of the various workers or community health workers, those who are in many cases not only underpaid, but I think we also have to add that they're undervalued. It is only through COVID and when people have had personal experience that I think the value comes out, not only in terms of how people see it, but in terms of their hearts and their minds. And again, at a more macro level, we're dealing with a situation of vexing questions of finance. And to answer in part some of the questions that I've seen in the Q&A, what we're being told about there not being enough money, are we really convinced of that when we hear about all the billionaires? Are we to rely only on the kindness and philanthropy of strangers? Or should we have a fairer tax system and tax rules that will ensure that we become a society that really cares for each other? So at that level, PSI and other global union federations, along with our allies, are campaigning vigorously for a change in the global tax rules to ensure that those who earn the highest, or millionaires or billionaires, the large companies, pay their fair share of tax. We need to do something about corporate taxation. That's what will bring in the money to ensure that these workers are effectively recognized, that they're paid well, that they have decent work. Thank you very much.
Thank you so much, Sandra. Absolutely agree with you on the issue of financing. And certainly, I think there is a tremendous role for global and national trade unions to really shift the narrative for health workers that are not compensated and don't have safe workspaces as well. So thank you so much for sharing your insights. It was great to hear your experience. So let me move to you, Bhanupriya. India has well over 1 million women working unpaid and underpaid in core health system roles. What impact does this have for the health system and the women themselves directly?
Right. Thank you, Desta, and thank you so much for inviting me for this event. I couldn't agree more with my previous panelists, especially around the question of financing. And I was vigorously nodding my head when Sandra was talking about how, the vexing question of finance, where, all we need is a fairer tax system and a fairer system of distribution. I was also pretty taken aback by one of the statistics that was presented in the report, which is that $3 trillion are contributed by women healthcare workers, women in the healthcare system, and half of that is unpaid. And so this is where I'm going to sort of take it off into my experience, especially from India. Mainly because we've reported we've reported during the pandemic the whole the whole contribution and the effort of the 1 million ASHA workers. And these are just the ASHA workers that are, that are within the healthcare system. There are different other levels of unpaid workers in India who basically hold on the childcare system, in the Anganwadis as we know it, like the ones that run community creche facilities, the ones that cook midday meals. So these are all voluntary and unpaid roles, basically. So every welfare sort of program in India, which is held up by the women workers, is basically underpinned by unpaid or voluntary work system. And when I say unpaid because it's not as if they are not paid paid at all, but they're paid such basic minimum that that it is even shameful to talk about, commensurate to the amount of work that they put in terms of the number of hours and so on, but also how valuable they are to the health system or for the childcare system or for any other system within the country. So in terms of ASHA workers alone, what we've, in India, the system started in 2005, and in the beginning, it was completely unpaid, and later on, with a lot of effort from different activist groups and different forms of different pressures, what they were starting to get paid until even 3-4 years ago was about 2,000 rupees per month, and that is equal to, say, I think about $20 or $30 per month, which then was increased to 3,000 rupees. But all of this is not and that's about $42. But all of this is still a conditional amount. So it is not for the work that they are paid for. But even this $42 a month is paid only on the event of completing a set of 8 tasks, right? And anything above that is paid for by incentives. So if community health workers or ASHA workers have a set of 66 odd tasks that are assigned to them, and they range from the payment, the incentives for completing any of these tasks range from 300 rupees, which is about $4, to sort of, or to something like even 1 rupee for distributing, say, ORS packets or or condoms and so on and so forth. So essentially what an ASHA worker makes is there isn't a set amount of money she makes, but it can go up to say around 10,000 rupees on a very, very good month when she has been able to complete sort of take a good number of women for institutional deliveries. But to your question on what impact does that have for ASHA workers, a whole lot, really, because I mean, imagine a cadre of workers that is working from, say, there are no fixed hours of work. So if a woman goes into labor at 3 in the night or whatever odd time, it is the ASHA worker's job to take the woman to the nearest district hospital or a public health center, failing which she will have to take the district hospital, stay with the woman until she has delivered and she was ready to be brought back home. It's only then, on the completion of this entire cycle, that she gets paid the money that is due for that. Now, in terms of has all of this empowered, I think that question has been answered before, but and brilliantly, that empowerment comes only if the pay is fair, if what they're owed is paid to them. In India's case, what ASHA workers and Anganwadi workers have been fighting for so many years is that that these women are such crucial parts of the healthcare system, but they are when you categorize someone as volunteer workers, you're essentially saying that you're important for the roles that you perform, but you're not part of the healthcare system. So many ASHA workers have told us that there is almost this sort of a pariah sort of treatment, which can be seen both in terms of the emoluments, the money that they get and the benefits, etc., but also in terms of the way they are treated by other sort of healthcare workers, whether it's the doctors, lab technicians, auxiliary nurse midwives, who are their superiors, really, who are the people that ASHA workers are reporting to. So when a system doesn't treat you as their own, it is, to say it mildly, it's hurtful, but also it is in so many ways unjust, because in that system, you are not paid a fair wage, but you're not treated part of the system, which means you're never regularized. You will continue to be a volunteer worker. You will never receive any of the benefits and social security benefits that come with it, which means that even something like maternity benefit is not available to the ASHA workers. It also means that this whole unpaid and this voluntary work also means that so many other sort of simple humane benefits, like if an ASHA worker has taken a pregnant woman to a district hospital, there are no waiting rooms for an ASHA worker. They are asked to go and sit outside, wait outside, treated badly, so all of this has a lot of, not just sort of the economic implication of it, but it in a lot of our interviews with ASHA workers, especially during the pandemic, we've seen the kind of toll it takes on their mental health. And I think that is the bit that has not been focused upon quite a bit. We've all celebrated their contribution and so on to the whole both healthcare system, and especially during the pandemic. But I think what needs to be paid attention to quite quickly is the kind of mental toll that years of this kind of neglect has taken, and especially during the pandemic, basically because their protection, PPE equipment was not available for them. I remember one ASHA worker who told me that, in one of the contact tracing events, when she figured out that this person was positive, then the rest of the other healthcare team comes and kind of isolates the person. And when that happened, the other healthcare team came and gave her the hazmat suit. And she very proudly took a picture of herself and put it in her WhatsApp group. And her supervisor really admonished her for wasting a hazmat suit on herself, which was,
there's so many stories like that, Banupriya, and I don't mean to cut you short, but I know that we have a few other questions to get to, and you raised the big issue of mental health. Certainly that is something that we are seeing increasingly as a result of COVID. So I want to stop right there, Banupriya, and thank you for sharing your insights into the role of the unpaid health workers in India. And I want to move to just some more general questions, and our time is running out a little bit here for the panel. So I want to give each of you 3 minutes and ask you to answer one question, if that's okay with you. So I want to come to you, Svea, and ask you the question, and try to wrap it up in about 3 minutes so that we can move on with the program. How do you think the pandemic has impacted women working unpaid and underpaid in health systems? And how do you think we can build back equal after the pandemic?
Well, actually, a worker in Baltimore summed it up for me better than I can say anything myself. And what they said was that the pandemic has accelerated all of the existing issues, right? So, I mean, PPE, which Banupriya just mentioned as an issue for ASHA workers in India, was also an issue for community workers in Baltimore, right? That some of those mental health issues around, am I valued? Does anyone care about the risks I'm taking? Really came to the fore during the pandemic, because it actually became clear to many frontline workers that they weren't valued in the same way that doctors and nurses were. And that was painful. So that set of issues, I think, was very painful for many workers, and they haven't forgotten. Yes. And so I think part of building back better is acknowledging that, we haven't always valued the work of these women, because they're mostly women, in terms of pay, in terms of respect, in terms of things like PPE, which is, basic protections that we didn't always acknowledge that their risks were just as real as the risks of doctors, right? So part of building back better is acknowledging that these things have happened, that the system hasn't been fair, and really working hard to find ways to build back systems that place these frontline workers. And, this is community health workers. It's also workers like environmental service workers, for example, in hospitals, right? Who are also often women. To put these sorts of care workers right at the center and build them into teams in a way that really values the work that they're doing, both financially and, morally, kind of, to build on what other people have been saying.
Thank you so much, and that's really important. Acknowledging and valuing; those are really important terms to keep in our mind as we move forward. So thank you so much, Svea. Sandra, I want to come to you for just a minute there. Have you seen any policy measures or programs that have made a difference for unpaid women health workers that could be scaled or replicated elsewhere?
Yes, thanks for that one. And actually, yes, we've been able to make some inroads, I think, with our work with community health workers in Pakistan. A group of community health workers actually got together, started as a rather loose group, and given the lack of recognition at the time to trade unions in Pakistan, it was like going out on a limb. But we were able to provide them with the guidance and capacity building efforts that they have now become a full-fledged trade union. They've been making their representation to government in Pakistan. They've been able to recover what we call the wages that were stolen from them as volunteers, and are actually continually building their strength and ability, not only to gain more respect and to achieve decent work, but actually to increase their numbers and in a way influence the kind of work that is being done in their particular state, as well as spreading it throughout Pakistan. But even more than that, I think, is that if we look at globally, to take some of the other examples that may not only apply to unpaid care work, but also to look at what's been happening generally about equal pay for work of equal value. And the kind of legislation, for example, in Canada that came into force in Canada, I think it was August of last year, that makes it proactive for the countries, the provinces, the states to start ensuring that there is a mechanism, there are ways of ensuring that we value the work that women do and that that work is paid for on the basis of the value that it provides, not only to the one who's directly receiving the services, but certainly to the society as a whole. Those are two quick examples, and they're replicated in other places.
Thank you so much, Sandra. Thank you so much. And Panupriya, I'm going to come to you and ask you to just very tightly answer this question. Policymakers, often say they applaud and value the work women do in unpaid health systems, but budgets are very limited and there's no money to pay for them. How can we change that? And if you could just do that in 2 minutes.
Yeah, I think the unions have been trying very hard. At least in India, they have been trying really, really hard across time, and especially during the pandemic, to impress upon that. I think the important thing here is for governments to recognize and budget for that. If you have a cadre of staff that you depend on, and that is a staff, just like you would make budgetary allocations for any other healthcare staff or any other staff within the system, it's as simple as that. If you valued and if you realize the value of work of the women workers, then you would definitely try to budget for the remuneration of these workers also. So I really don't buy this argument that governments do not have the money. Why, if they have money for everything else, then they can have money for this too.
Thank you. Thank you. Maybe you can just leave us with one last piece of advice on how we can achieve economic justice for all women healthcare workers. And let me start with you, Svea. Unmute yourself.
Yeah, I think we all have to work together to get there, right? I mean, I don't have a piece of advice except really to say that I'm so heartened by the sorts of conversations that have been started here, and I hope we can continue them and work together to going forward to achieve that.
Thanks so much. Sandra, one last piece of advice.
Sure. We have to reclaim the public nature of care services. We have to recognize that health and care are human rights, and also to ensure that this is a very clear understanding and advocacy and lobbying around the fact that the primary responsibility of the state, or one of the primary responsibilities of the state, is to provide public health and care services, and to develop the systems that are transformative, not only for the population, but certainly in relation to gender relations and women's lives.
Thank you. Thank you so much. Panupriya, I'm coming to you. If you could give us a word of advice here.
I think, yeah, I agree with Sophia and Sandra that I think there needs to be more collective action. I think we need to keep amplifying the voices. The one thing I believe the pandemic has done is, at least I can tell you in the case of India, is to help the public understand the existence of ASHA workers. So I think and we have consistently written about it, and so have so many other organizations. So I think some amount of pressure is being built on the government, and as our ASHA workers building them. So I think the only way that any kind of economic justice can be achieved is for them to pay what they deserve and to be treated as a regular healthcare staff.
Absolutely, absolutely agree with that. And with that, I want to just wrap up our panel discussion. I want to thank our panelists. I wish we can all meet in person and have broader, longer conversations around this. Really important things that have been raised in this conversation. So thank you to all of our panelists, really, for sharing their experience, their expertise with us today. And with that, I'd really like to turn the floor to Magda to give her closing remarks.
Thank you. Thank you very much, Desta, for moderating this session for us. In closing, I would like to thank all our speakers and panelists today. It has been truly inspiring to listen to your perspectives, reflecting experiences of women's unpaid work from different contexts. And I thank Ernita, our community health worker from Kenya, for a personal testimony. It is critical that we enable women health workers to tell their own story, and that we all could learn from that and pave the way for a better working conditions and a better health systems, community systems for all. The piece of work done by Women in Global Health on women's unpaid work in health systems is a good beginning, and we believe it builds on valuable work done by Sphere and other researchers, but there is a lot more to be done to map comprehensively the work done unpaid by women in health systems. While this work is invisible in national statistics, it will remain unvalued and unpaid. We need to turn this upside down. We need to overturn this. We need to make women's work visible so that it can be valued and it can be paid accordingly. In 2001, Women in Global Health launched the Gender Equal Health and Care Workforce Initiative with France and the World Health Organization, which we now lead with France. The initiative aims to build a political consensus to address gender inequity in the health and care workforce, including decent work and pay for women in the workforce. Women have carried us throughout this pandemic, but after 2 traumatic years on the front lines of patient care, women health workers are burned out and exhausted. We are at a crisis point with significant numbers of women health workers planning to leave their jobs, feeling that their contribution has not been valued. Paying women a fair wage for the work they do is of critical importance for the economic empowerment of women. By treating women health workers as volunteers, we idealize them as altruistic and mask the poverty of large numbers of these women. Gender equity in the health workforce is not a marginal women's issue. It is central to strong health systems and global health security. We are asking, therefore, for a new social contract for women in health that recognizes and values their contribution. Women in the health and social sector want the means, they want decent work, they want safety, they want dignity, they want fair pay, and they want equal leadership to do their jobs better so that they can deliver the best possible healthcare for everyone. We want all health workers to be paid a fair wage for the work they do, with social protection to support them when, for example, they are older or they get sick. And we need all health workers to be protected from the physical and mental stresses and risks of the work they do. In caring for health workers and promoting their well-being, we protect ourselves, we protect our societies, and we protect our nations. Please let me take this last minute to invite you to encourage your organization and governments to join the Gender Equal Health Workforce Initiative, and let us continue on the journey to a more equal world together. Once again, thank you all for being with us today. We wish you a very good rest of your day, and with these words, I declare this event closed. Thank you.
Thank you, Magda. And if I can just add, even as you close, there were some questions in the Q&A, and I just wanted to assure everyone who's attending that the questions will be answered and the answers will be shared with you in addition to the recording of today's session. And I echo Magda. I thank you so much. It has been a stimulating discussion. Have a